Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will present a new subject on pediatric surgery made easy, which is inflammatory bowel disease. It's a very important topic for all pediatric surgeon and pediatrician. Let's start. Inflammatory bowel disease. Major disease affecting children in the developed countries mainly, with gastrointestinal manifestation and extraintestinal manifestation. By the end of this presentation, you should be able to know what is the etiology of the inflammatory bowel disease and what is the pathology, what is the clinical manifestation of inflammatory bowel disease, how to diagnose inflammatory bowel disease, and how to treat medical management and surgical management. At first, inflammatory bowel disease is a chronic inflammatory disease of the gastrointestinal tract, mainly divided into three types. Number one is called ulcerative colitis. There is an inflammation and ulceration of the colon mainly, starting in the rectum and spread proximally to affect the colon. Number two is Crohn's disease, types of granulomatous disease affecting mainly the small bowel and also may affect the large bowel or any segment of the gastrointestinal tract. And the third one, if there is no clear demarcation between ulcerative colitis and Crohn's disease, and you cannot reach a definitive diagnosis. In such case, the diagnosis will be classified as indeterminate colitis. Actually, pediatric surgeons caring and treating these children are faced with a difficult medical and surgical challenge. Although the clinical, radiological, and pathological feature may differentiate Crohn's disease from ulcerative colitis, however, up to 25%, the diagnosis cannot be specified, leading to the diagnosis of indeterminate colitis. Also, the treatment. Regarding medical treatment for the inflammatory bowel disease, it shared the similar strategies. However, the surgical treatment is different. In ulcerative colitis, the surgical treatment is curative by removing the affected part of the bowel, the colon and rectum. However, in Crohn's disease, surgery is not curative because the disease may affect any part of the gastrointestinal tract. The disease is characterized by relapsing and recurrence. So surgery is limited to treating complications. And this must be explained very well to the patient and their families, because the child may need several surgeries. So the patient and families should be informed about this possibility. We will go through the topic as in the following scheme. IBD or inflammatory bowel disease may be classified as ulcerative colitis, Crohn's disease, indeterminate colitis. We will try to answer these 8 items. Number 1, what is inflammatory bowel disease? Number 2, what is the incidence of inflammatory bowel disease? And what is the etiology? What is the pathology? what is the clinical presentation, and how to diagnose, how to treat, medical treatment. We will speak about what pediatric surgeon should know about medical treatment and surgical treatment of inflammatory bowel disease. We will speak about the pediatric surgeon perspective and the patient perspective or point of view. Number one, what is IBD, inflammatory bowel disease? What is ulcerative colitis? It is a mucosal-based inflammatory bowel disease that results in inflammation and ulceration of the colon and rectum. It varies in severity from mild disease to severe, fulminant, and potentially fatal disease. Usually the disease starts in the rectum and spread proximally to affect the colon. Sometimes whole colon is affected, and it is called pancolitis. Pediatric onset ulcerative colitis is characterized by many characteristics that differentiate it from adult onset of the disease. Number one, usually extensive at diagnosis. Number two, widespread disease is associated with more disease course. Number three, the risk of colectomy in children within 10 years is higher than that for adults. Number four, may affect growth and puberty as a disease occur in children and in prepubertal and adolescent children. So these four characteristics are for the pediatric onset ulcerative colitis. On the other hand, what is Crohn's disease? It is a type of inflammatory bowel disease, initially described by Crohn's, and bearing his name, he described the disease as regional ileitis. So originally believed to be isolated to the terminal ileum only. But now the disease described as occurring anywhere from the mouth to the anus, affecting any segment of the gastrointestinal tract with skip areas. Affected or active disease separated with normal parts of the bowel. Also, pediatric onset Crohn's disease, characterized by, number one, more extensive distribution at presentation, and the extension of the disease is also more extensive than adult. Number two, growth failure is present at diagnosis in about 10 to 40% of affected children. Number three, the disease or the onset in pediatric is associated with psychological and social morbidity that may have impact on the education, relationship, sexual development, and adherence to therapy. So the pediatric surgeon must understand that pediatric onset ulcerative colitis and pediatric onset ulcerative and pediatric onset Crohn's disease is different from that of the adult onset ulcerative colitis and adult onset Crohn's disease. The question now, what is the incidence of IBD? Is it common or not? The incidence of ulcerative colitis is about 0.1 to 0.7 per 1,000 children, male and female, diagnosed with equal frequency, and Western and Jewish societies diagnosed 4 times more than the developing countries, although this finding seems to be changing nowadays. Also in Crohn's disease, the incidence changed in the last few decades from 1.3 to about 3.1. Crohn's disease occurs also equally in the male and females and it's 5 times more common in Caucasians than African Americans, with a higher incidence in Jewish population. Crohn's disease is more common in children than ulcerative colitis. Crohn's disease occurs more commonly in white population. What is the etiology of the ulcerative colitis? Exact etiology is unknown. However, many theories proposed trying to explain the etiology. They suppose that the disease may be genetic, or may be infectious, or maybe there is an immunological disturbance, or maybe environmental factors that are responsible for causing the disease. For genetic factors, evidence suggests that the relative risk for the sibling with the disease is about 16%. Number two, the patient with extraintestinal manifestation may have high incidence of expression of the major antigen, HLW27. Also, anti-neutrophil cytoplasmic antibodies associated with ulcerative colitis, although this association may be in doubt, as some unaffected persons in the family of the affected child may already have this association without manifestation of the disease. There are some genetic predictors of disease severity, like NOT2 and C polymorphism, like single nucleotide polymorphism, like mucin abnormalities, and that genome-wide association studies found over 240 susceptibility loci in inflammatory bowel disease and more than 50 found related to ulcerative colitis. Also, variant on the 8.1 halotype shows strongest association with severe ulcerative colitis. This genetic association may propose that the disease is a genetic one, or there is a genetic relationship. So some children are more susceptible to be affected by this disease. Infectious etiology. Yes, some evidence reports that the cause of the disease is due to imbalance of the microbial flora in the normal, healthy intestine. However, up till now, there is no specific infectious agent responsible for causing the disease. Also, immunological disturbance. Pediatric surgeon suggests that the disease, ulcerative colitis disease, is a disease of autoimmune dysregulation, and that there is maybe cytokines expression, interleukin-1, interleukin-6, interleukin-1 receptor agonist. All these cytokines may show imbalance in ulcerative colitis patient. Some environmental factors may be involved. Some factors may be protective, and some factors may be risk factors. Cigarette smokers, appendectomy, breastfeeding, diet, some infections, and some types of mycobacterium, para, tuberculosis, and oral contraceptive. On the other hand, what is the etiology of the Crohn's disease? Also unknown etiology, seem to be multifactorial. The chronic relapsing features of the Crohn's disease suggests that there is maybe predisposing event in a susceptible host. Maybe predisposing in a susceptible host. There are also some hereditary risk factors for the Crohn's disease. 5 to 20% patients with the Crohn's disease have a first-degree relative who has IBD. The offspring of the Crohn's disease patient have a 10% a chance of developing Crohn's disease. Genetic factors. Genetic factors found that some patients with NOD2 gene on the chromosome 16 have a highest rate of Crohn's disease susceptibility. Also, there are 3 areas of polymorphism that may increase susceptibility for the development of Crohn's disease. Also, the relationship between some genetic mutation seem to be related to the early disease onset in children. Imbalance in the compositions of the intestinal microbiome may explain increasing Crohn's disease with the use of antibiotics and antimicrobial agents. This supposes that the microbes of the patient with a Crohn's disease characterized as dysbiosis. Dysbiosis means more total number of the bacteria, but less variety. Number 2, increase in the number of the pathogenic microbes. The question now, what is the pathology of inflammatory bowel disease? What is the pathology of ulcerative colitis? We can speak about the pathology of ulcerative colitis. It is a mucosal-based chronic inflammatory disease that progresses to mucosal ulcer. So there is inflammation and ulceration of the mucosa. Start in the rectum and then extend proximally to involve the colon. In some cases, the whole colon is affected, and it is called pancolitis. Regarding small bowel, ileal involvement, if it is present, it suggests that the disease may be Crohn's disease and not ulcerative colitis. However, there is a condition called backwash ileitis. Backwash ileitis is a low-grade inflammation of the ileal mucosa, may be seen in the patient with ulcerative colitis. So ulcerative colitis mainly limited to the rectum and colon, may involve the distal ileum with backwash ileitis. The microscopic finding in ulcerative colitis will be diffuse, unspecific superficial inflammation, maybe crypt abscess and deformity, maybe mucosal ulceration with the progress of the inflammation, and there is maybe pseudopolyp with regeneration of the epithelium. With more chronic disease, the affected colon may become thick, stiff, and short. What is the pathology of the Crohn's disease? The Crohn's disease differs from ulcerative colitis in several important points. Number 1, Crohn's disease is a transmural inflammatory disorder, affects all the layers of the bowel, unlike ulcerative colitis, which is mucosal disease. Number 2, Crohn's characterized by granuloma formation and the intestinal wall thickening. Number 3, the involved bowel and mesentery in the Crohn's are thickened and fat wrap or creep around the wall of the bowel. This is called fat wrapping or creeping fat. As you see in this picture, the fat creep all around the bowel wall is not normal. This is called creeping fat or fat wrapping, which is one of the pathological features for the Crohn's disease. Also, there is maybe areas of stricturing due to granulomas, fibrosis, thickening. There is maybe areas of stricturing or narrowing in Crohn's disease. The skip lesion is a characteristic for the Crohn's disease. Areas or batches of the active disease outside the main area of the involvement, typically found in the small bowel, proximal to the most commonly affected terminal ileum. Fissures and ulceration are common and may be separated with areas of the normal mucosa, unlike ulcerative colitis limited to the rectum and colon. Crohn's may spread all over the gastrointestinal tract with the presence of skip areas normal in between the pathologically active disease. Ulcers, yes, may be present in Crohn's disease. However, in Crohn's, they penetrate deep into the muscularis and can progress to perforation, formation of the sinus, fistula, chronic abscess. Unlike ulcerative colitis, superficial ulceration. Granulomas is a characteristic and may help to differentiate Crohn's from ulcerative colitis. Crohn's disease, as we said, may involve any part of the gastrointestinal tract. Maybe the terminal area, which is predominantly involved. Maybe the colon and rectum, yes. Crohn's disease may affect the colon with Crohn's colitis. However, in most cases, the rectum is usually spared, which is one of the characteristics for the diagnosis of the Crohn's disease. Appendix frequently involved. In many cases, the pediatric surgeon operates for a child with a diagnosis of acute appendicitis, and surprisingly, he found that there is inflamed terminal ileum and the diagnosis is Crohn's disease. Upper gastrointestinal tract may be affected with Crohn's disease, even the oral cavity, pharyngeal cavity, and esophagus. Now the question is, what is the clinical presentation of ulcerative colitis and Crohn's disease? Regarding ulcerative colitis, commonly diagnosed in young adults, about 4% have the onset of symptoms before the age of 10 years, and 17% present between the age of 10 and 20 years. Presentation of ulcerative colitis is usually divided into intestinal symptoms or manifestation and extraintestinal manifestation. Number one, intestinal manifestation. The most common presentation in ulcerative colitis is resistant diarrhea that progresses to hematochezia, fresh blood per rectum, with a mucus and periods. So the common presentation in children with ulcerative colitis is resistant diarrhea that is often bloody. Number two, tenesmus, anorexia, weight loss, and growth retardation as a disease affecting growing children or pre-adolescent children. In about 15%, the presentation may be fulminant or severe presentation, may be profuse bloody diarrhea, severe cramping abdominal pain, fever, and sepsis. However, the main presentation is bloody diarrhea. With more chronic disease, most patients will develop what's called chronic colitis, with periods of quiescence followed by periods of exacerbation. What about the colorectal cancer risk? Yes, there is a risk for colorectal carcinoma in children with ulcerative colitis, estimated to be about 3% in the first 10 years after initial diagnosis of the disease. And the incidence rise to about 20% per decade after the first decade. Quiescent disease doesn't protect from the cancer, and also the young age of the children may be a risk factor for the development of subsequent cancer. This risk of carcinoma should be put in mind for the pediatric surgeon who treating this disease as the child is growing, as there is a risk for subsequent carcinoma, and to remove all the diseased mucosa. Extraintestinal manifestation. You should imagine that the disease is inflammation and there is also autoimmune dysregulation. So manifestation of the disease may be related to both elements, to the inflammatory element and to the autoimmune element. Number one, growth retardation and delayed bone growth. The chronic inflammation present has a direct effect on the growth and development. So adequate disease control can prevent or delay these complications. Number two, delayed sexual maturation may be present and related to low gonadotrophin level. Arthralgias may occur in about a quarter of patients and usually misdiagnosed as a rheumatoid arthritis before the gastrointestinal symptoms become obvious. And these children may be wrongly treated as rheumatoid arthritis. There is maybe also skin manifestation, erythema nodosum like this, tender red subcutaneous nodule, or may progress to what's called pyodermia gangrenosum, chronic deep ulceration of the skin. Although more common in adults, both may affect the children and usually resolve with the treatment of the primary disease. Primary sclerosing cholangitis. There is a strong association between ulcerative colitis and PSC. 3 to 7% of patients with ulcerative colitis may have primary sclerosing cholangitis. And also the liver function may be abnormal in up to 10% of children with ulcerative colitis. When abnormal liver function is identified, the pediatric surgeon should be alert for the possibility of PSC, and the child may require close observation. Anemia, frequently present, and may be due to chronic intestinal bleeding, as we said that the disease presented with diarrhea that is often bloody. Anemia may be related to the chronic inflammation. Also, ulcerative colitis patients are more susceptible to thromboembolic complications, as a venous thromboembolism. Osteoporosis and osteomalacia may be related to decreased calcium absorption, increased urinary loss of calcium. Prevalence rate may be reported to between 2 and 20%. Nephrolithiasis can develop due to chronic oliguria or increased water loss. The most important is the emotional and psychological distress. The children may show signs of depression or may show withdrawal from the social and physical activities. And usually emotional distress is identified as a precipitating factor in the patient with relapsing disease. So the treatment of these children must be performed in a multidisciplinary approach, and the pediatric surgeon must consult psychologists and psychotherapy for these children to treat or avoid the development of emotional and psychological distress. To summarize, the clinical presentation may be summarized as intestinal abdominal pain, diarrhea, hematochezia, mucus in the stool, purulent exudate, tenesmus, anorexia, weight loss, extraintestinal like growth retardation, delayed sexual maturation, arthralgia, skin manifestation, anemia, PSC, nephrolithiasis, osteoporosis, depression, and emotional distress. On the other hand, what are the clinical presentations of the Crohn's disease? The predominant symptoms here is weight loss. In ulcerative colitis, it is profuse, bloody diarrhea, or resistant diarrhea that is often bloody. Here is weight loss. Crohn's disease typically diagnosed in young adulthood. However, its incidence in children is increasing, with about 20% new cases diagnosed in younger children. The main presentation here is acute pain, up to 75%, usually non-specific and persistent pain. Palpable mass may be present in the right lower quadrant. The disease performs granuloma, thickening, fibrosis, so there is maybe a mass. Maybe diarrhea, yes. Also, diarrhea happen in the cases where Crohn's disease affecting the colon. Gross impairment in about 1/3 of patients and maybe multifactorial. Perianal disease is one of the characteristics of the Crohn's disease. In about 25% of patients may be presented with deep non-healing fissures, abscess, or maybe large skin tags. So pediatric surgeon should be alert for the presence of these manifestations in the Crohn's disease, as it may present with perianal or perirectal disease. Fistula is more common, maybe enterocutaneous fistula, or maybe fistula between the bladder vagina, so was adjacent lobe of the bowel or large bowel. Extraintestinal manifestation may be present here also, like ulcerative colitis. There is maybe weight loss, growth retardation, delayed puberty, skin lesions also may be present, liver disease, arthritis, anemia, uveitis, stomatitis. So it's a combination between inflammation, autoimmune dysregulation. Inflammation of the gastrointestinal tract, that may be superficial. In ulcerative colitis, that may be deep and penetrate with sinus, fistula, abscess in the Crohn's disease. However, both diseases are affected with autoimmune dysregulations in the other systems. How to diagnose? Very important question. How to diagnose IBD? In ulcerative colitis, the presentation is usually with persistent diarrhea. So the evaluation usually began with the investigation for what is the cause of this diarrhea. Usually stool cultures and stool analysis, searching for the infectious causes of diarrhea. Salmonella, Shigella, Campylobacter, Clostridium difficile, Entamoeba histolytica. In the Crohn's disease, the matter is different. The diagnosis may be delayed by non-specific nature of the presentation. Non-specific abdominal pain present in most cases. So patient with Crohn's disease need high index of suspicion by taking proper medical history related to the bowel symptoms, stooling pattern, exact data on the growth in the last year, and also family history of inflammatory bowel disease. So this is very important. The beginning of the diagnosis will differ between ulcerative colitis and Crohn's disease. We can depend on some laboratory tests, some serum markers, although not definitively approved, some immunological testing, and radiology, endoscopy, and scores. Laboratory finding, usually not specific, may show anemia, elevated C-reactive protein, increased sedimentation rate, also prolonged prothrombin time. Serum markers for IBD have not proven to be reliable as yet, including the perinuclear anti-neutrophil cytoplasmic antibody is found to be positive in about up to 80% of ulcerative colitis patients and less than 30 in Crohn's. So more specific for ulcerative colitis. Anti-Saccharomyces antibodies also may be found in ulcerative colitis and in Crohn's disease. Also, there is some what's called pancreatic autoantibodies shown to correlate with ulcerative colitis. Some immunological tests may be needed in atypical presentation and the children less than 2 years. Lymphocyte phenotyping, immunoglobulin levels, lymphocytic response to antigen and mitogens. Fecal inflammatory parameters is useful, called calprotectin and lactoferrin in ulcerative colitis, may help to differentiate colitis from non-inflammatory diarrhea. Calprotectin also may be used to follow the response of the medical treatment. Stool culture to exclude infectious causes of the diarrhea and for some other pathogen. In Crohn's disease, the calprotectin and lactoferrin usually help in the diagnosis and follow-up of the Crohn's disease, especially if the Crohn's disease involves the colon. In such cases, it will be challenging for the pediatric surgeon as ulcerative colitis is commonly affecting the colon and rectum. So in a child with Crohn's colitis, it may be difficult to diagnose that the disease is Crohn's, not ulcerative colitis. What about the radiology? CT and MRI, with improved visualization and characterization of the disease, these investigations become more valuable in the diagnosis of IBD. The upper gastrointestinal series may be helpful to detect small bowel disease, which is present in Crohn's disease. As we see in this finding, there is what's called lead pipe appearance of the colon, intensely inflamed and thickened colon, demonstrating the presence of ulcerative colitis. In both sections, you can see that the lumen is very narrow, the wall is thick, there is intense inflammation, and this sign is called lead pipe appearance of the colon. Radiology in the Crohn's disease include contrast upper gastrointestinal series to detect small bowel, CT enterography, and MR enterography. This avoid radiation can detect the presence of a peristaltic segment of the midgut that is affected by the disease. What about endoscopy? It's very essential and very important in both ulcerative colitis and Crohn's disease. It's very important to confirm the diagnosis and to take biopsy. It's recommended at first diagnosis before major treatment make changes to the disease manifestation. So recommended to perform the first endoscopy at diagnosis and document the results and to take biopsy. First biopsy is the most informative, as the post-treatment biopsies are modified by the treatment and the chronicity of the disease. And the endoscopist should be familiar with the typical and atypical features of the pediatric onset ulcerative colitis and Crohn's disease. Typical endoscopic finding in ulcerative colitis will be related to the mucosa, friable inflamed mucosa, fibrous exudate. Also, there is maybe ulceration. In pancolitis, the terminal ileum and the ileocecal valve may show non-erosive edema and erythema from backwash ileitis. Biopsies provide histological diagnosis, however, with severe inflammation. The biopsy is sometimes non-specific, and the experienced endoscopist may rely on the endoscopic appearance. Upper gastrointestinal endoscopy also very important, with taking biopsy from the duodenum, stomach, and esophagus. As in ulcerative colitis, there is maybe gastric erosions and small ulcers. Also, focal gastritis or duodenitis may occur in both ulcerative colitis and Crohn's disease. And the biopsy in the Crohn's disease is typically formed of granulomas. So granulomas is a characteristic for the Crohn's disease. In Crohn's disease, endoscopy is very helpful to differentiate ulcerative colitis from the Crohn's disease. Upper endoscopy and with biopsy, as granulomas is more common in the upper gastrointestinal endoscopy, it's very important to take biopsy from the upper GI endoscopy. Full colonoscopy with ileal intubation passing into the terminal ileum is required for the proper lower gastrointestinal endoscopy. The normal rectum or rectal sparing is more suspicious of the diagnosis of Crohn's disease, as ulcerative colitis is usually start in the rectum and spread proximally. However, there is some cases with Crohn's disease and rectal affection. Recently, capsule endoscopy. It's an non-invasive form of endoscopy to imagine the small bowel and diagnose the presence of the affection of the part of the small bowel in Crohn's disease. It's very important to visualize entire small bowel with minimal discomfort now can be swallowed by children and can be safely used in children. However, there is some limitation like the potential to miss single lesion in the small bowel, high rate of incidental finding, and difficulty in localizing the lesions. Sometimes, which is very rare, is a capsule retention is a retention of the capsule above area of narrowing or strictures, as a Crohn's disease is usually related to bowel narrowing, stricturing, fibrosis. There is an important score for ulcerative colitis and for Crohn's disease, Pediatric Ulcerative Colitis Activity Index. It is a score used to assess the disease severity and to follow the response to the treatment. So it depends on items like daily abdominal pain, rectal bleeding, number of stools per day, stool consistency, nocturnal stool, and activity level. The maximum score for ulcerative colitis is 85. Score less than 10 indicates remission of the disease. Score more than 65 indicates severe disease. Quarter of the patient present with score more than 65 and severe disease. Change of the activity can be followed after the treatment as a significant change if there is more than 35 points improvement or moderate or small or none improvement. So in the medically treated ulcerative colitis, this score is non-invasive method for follow-up the response to the treatment. Also, the physical finding related to should be assessed, including gross failure, abdominal pain and tenderness, mass, preanal disease, and extraintestinal manifestation. Pediatric Crohn's disease activity index, used also to monitor the Crohn's disease, including abdominal pain, general well-being, stool frequency, extraintestinal manifestation, physical examination, and some laboratory data. The score here is formed of about 70 points. Score of less than 10 demonstrate inactive disease. Score of 40 or greater is severe disease. How to treat? This is very important for the pediatric surgeon. This is the cornerstone of the presentation today. How to treat inflammatory bowel disease. The treatment usually performed by multidisciplinary team. The gastroenterologist, the pediatric and the pediatric surgeon, the psychotherapist, all this will be integrated to treat the disease. Surgery is a part of the treatment. Medical treatment is very important also. Our goal is to alleviate symptoms, provide normal growth and development, avoid complications. Regarding medical treatment, what pediatric surgeons should know about medical treatment. The medical treatment is expanding nowadays. There is many groups of drugs. So the question is what the pediatric surgeon should know. Regarding ulcerative colitis, the treatment usually classified according to the disease severity, mild, moderate, severe. Regarding Crohn's, the problem here is the treatment is neither entirely medical nor surgical. So some children may need medical treatment, some children may need surgical treatment, and others may need combination. This is the current medical treatment pyramid in the inflammatory bowel disease, guided by the years of the development. This is the first drug described at the base of the pyramid, 5-amino acid, 1942, followed by the steroids, 1950, followed by the immunomodulators group of the drugs, 1960, followed by the development of the biological drugs. Regarding the first category, aminosalicylic acid, it is used for acute flare and maintenance therapy of the mild ulcerative colitis or moderate ulcerative colitis. Drug can be used oral, can be used locally as enemas or suppository. However, this drug is mainly for the chronic disease, so it is less effective in the Crohn's disease. So used mainly for treating ulcerative colitis. This is the first group of drug used for acute flare and maintenance of mild, moderate ulcerative colitis, less effective in the Crohn's as it is mainly used for the chronic disease. The second group is steroids. Steroids used for therapy of acute flare only. It controls the moderate or severe disease after failure of aminosalicylic acid treatment, effective for induction of remission, but not for maintenance due to the side effect of the steroids. In patients with severe disease, steroids can be used intravenous. So this second group or steroids is very helpful for controlling acute flare and induction of remission of the disease. However, the problem is that you cannot depend on the steroids for maintenance due to the well-known side effect of the steroids as osteoporosis, osteopenia, insulin resistance, change in the body image, psychological alteration, gross disturbance. Also, if you decide to perform surgery, the steroids may have a bad impact on surgery. Increased anastomotic leakage with high dose steroids, and also you should prepare a stress dose for steroids after sudden removal of the treatment with steroids. So steroids, pediatric surgeon should understand that steroids is used for acute flare and to induce remission, but not to maintain it. The third group is immunomodulators, azathioprine and mercaptopurine. These drugs are used to maintain remission in children who have intolerance to 5-aminosalicylic acid or steroid complication. However, they generally avoided in children as they, number one, they increase the susceptibility for infection. Number two, they are now considered as a carcinogenic, increased risk of lymphoma and non-melanoma skin cancer. Moreover, its efficacy is reached after 12 weeks, so they need long time to induce remission of the disease. This is summarizes some side effects of the azathioprine: pancreatitis, elevated liver function, nausea, cholestatic hepatitis, bone marrow depression. The maximum efficacy is 12 weeks, so used for maintenance, not for induction, and carcinogenic, nowadays classified as carcinogenic, may induce non-Hodgkin lymphoma, squamous cell cancer. The fourth group is the biological drugs. Anti-TNF antibodies. These biological drugs control acute flare and maintenance therapy of moderate and severe inflammatory bowel disease. It used for persistently active IBD, steroid complication, anti-tumor necrosis factors are now approved in children, can be helpful in treating fistulizing Crohn's disease, perineal fistula. So infliximab is one of these groups that can be used to treat fistulizing Crohn's disease. Perineal fistula can be healed if infliximab was used. The question: do biological drugs increase the risk of perioperative complication? Actually, in the literature, no reported major post-operative complication if a patient used biological drugs submitted to surgical treatment. However, they reported to increase the rate of post-operative infection. So in elective surgery, it is recommended to stop the biological drugs 4 weeks before surgery. Stop the biological drugs 4 weeks before surgery to decrease the risk of possible infection. However, they are effective group used for acute flare and maintenance of moderate and severe IBD. There are novel IBD therapies, some recent drugs with high safety, like vedolizumab. It's one of the gut selective. It inhibits the lymphocyte migration in the gut, inhibits the inflammatory process, and block integrin on the surface of the lymphocyte. Currently being used in children, it is a selective drug with high safety. As we see that the newer categories of drug have a higher or good safety profile than the older one. Some pediatric surgeons suggest what's called top-down approach in the treatment, to start with infliximab and then go to other drugs. Start with the strongest one to get rapid results of treatment. So to summarize, medical treatment of IBD, what pediatric surgeon should know. The pediatric surgeon should know that the drugs classified into pyramids. At the base of the pyramids, 5-aminosalicylic acid used for acute flare and maintenance therapy of mild and moderate ulcerative colitis is less effective in the Crohn's disease, and it is mainly used for the chronic disease. Crohn's is a small bowel. The second category is steroids. It is a therapy of acute flare only, no maintenance therapy, due to the well-known side effect of steroids, diabetes and hypertension, many disturbance. The third one is immunomodulators, used for maintenance therapy of the moderate and severe IBD. However, they may be delayed up to 12 weeks, may be associated with increased infection, now considered as a carcinogenic, not recommended in children. The upper one is the biological drugs used for acute flare and maintenance therapy of moderate and severe IBD, and there is more development, and there is other groups with more on the good safety profile. This is what the pediatric surgeon should know about medical treatment. Now we will speak about the surgical management of IBD. Surgery is very important part for the treatment of IBD. However, the pediatric surgeon should understand what is the role of surgery in IBD, what is the patient perspective about surgery, and what is the pediatric surgeon perspective when to operate, how to operate, and how not to operate. Role of surgery is different. In Crohn's disease, the disease is usually troubleshooter. Chronic relapsing disease, many surgeries will be needed. Surgery is never curative, reserved usually for the complication. To resect or to dilate or to bypass, limited surgery related to complication. The matter is different for ulcerative colitis. Surgery is curative. However, it is a maximally invasive procedure for timing. The pediatric surgeon must take the decision when to do surgery. In about 25 to 40% of children in ulcerative colitis will require surgery by the disease duration of 10 years. Also, quarter of children are operated for fulminant colitis. What about patient perspective or patient point of view regarding surgery? Patients usually have a fear from stoma. Yes. Also, patient fear from pre-surgery morbidity, what's called pouch failure or infection or decreased fertility. Patient often well informed about the disease, reading more and more about the disease complications, sophisticated technique, even more than the pediatric surgeon. Some children also will need to be conducted lifelong. So pediatric surgeon must understand this patient perspective, must give time for the patient, explain the process very well, explain the expectation to the patient and family, and answers and respond to these fears and explain to the patient the importance of surgery, how to deal with the problem, what expected problem may happen. Pediatric surgeon perspective, yes, pediatric surgeon may be faced with emergency setting in IBD, perforation, bleeding, toxic megacolon, fulminant colitis. This is emergency situation. Or may be faced with elective setting, patient diagnosed with ulcerative colitis or Crohn's disease and need to be operated. When to operate? For ulcerative colitis, we may have two indications, emergency and elective. In emergency, maybe fulminant disease, perforation, extensive rectal bleeding, toxic megacolon that doesn't resolve or respond to the medical treatment. In elective, acute ulcerative colitis, steroid-dependent ulcerative colitis, finding of chronic dysplasia. So the situation is different, and the surgical strategies is differ between the two situations. In emergency surgery, the standard operative approach is total abdominal colectomy to remove the whole colon and perform end ileostomy. It's relatively fast, avoid the complications of anastomosis and the creations of reservoir or pouch, allow for delayed removal of the rectum, can be performed through the laparoscopy. So this technique is suitable for emergency surgery. You just perform total abdominal colectomy and bring the ileum to the skin as an end ileostomy. In elective surgery, the matter is different. Children should undergo at first full diagnostic workup, as Crohn's disease must be differentiated from ulcerative colitis as the treatment is different. As a Crohn's disease may present with colitis. So the pediatric surgeon should investigate well the child, endoscopy, CT interrography, MR interrography, to exclude or confirm the diagnosis. If the pediatric surgeon operates on a child with the diagnosis of ulcerative and finally the diagnosis was Crohn's disease, this child may be subjected to many post-operative complications. It's very important that all aspects and options of the surgical therapy discussed with the patient and parent regarding the possible post-operative complication, what is about the continence expectation, what is about the post-operative medical treatment to help to increase the stool consistency. The child will stop corticosteroids, yes, but may replace this treatment with another form of treatment. What about the potential sexual function and fertility? What about the post-operative stoma care? Very important items. All pediatric surgeons should be familiar with these items, and honest and reliable information should be explained to the patient and their families before surgery. How to operate? Actually, the philosophy of the treatment of ulcerative colitis is the same over the past many years. However, the treatment developed. At first, pediatric surgeon performed just stoma for the treatment of these ulcerative colitis, just stoma. However, the question, what does this stoma provide for the inflamed colon? Nothing. It's a form of diversion. This stoma may be incontinent or ileostomy or may be developed into Cook or continent stoma. Then the treatment developed to total proctocolectomy, means total removal of the colon and rectum and the anal canal, with performing permanent end ileostomy. However, this treatment usually refused by most children and families. The third one, or the third surgical option, is to perform colectomy, just removal of the colon, and perform ileorectal anastomosis. In such case, you will leave the rectum inside. This rectum is the site of the disease. So you leave the diseased part, and this patient will need lifelong surveillance with endoscopy. Recently, there is what's called restorative proctocolectomy or pouch surgery. In such technique, the pediatric surgeon removes the colon and the rectum and leave the anal canal and sphincter. Then perform anastomosis between the small bowel and the anal canal, aiming to preserve or restore the function of the gastrointestinal tract. This is the stoma, continent, conventional stoma, proc or continent or cook pouch. Provide little for the inflamed colon in addition to the fluid electrolyte derangement, many ileostomy complications, prolapse, parastomal hernias, and many complications. Total proctocolectomy, this is the second option with permanent endoileostomy to remove whole colon and rectum and the anal canal. And usually this technique and perform endoileostomy, this technique refused by the patient, and nowadays it is used only for the cases of failure. Colectomy is ileorectal anastomosis to remove the colon and leave the diseased rectum inside and perform ileorectal anastomosis. It's not recommended due to high failure rate, and most of these patients will require again proctectomy or removal of the rectum. Maybe consider in some selected girls who are primarily concerned about reduced fertility associated with proctocolectomy. During removal of the colon and rectum, there is maybe pelvic dissection, maybe leakage, maybe infection, and maybe some erectile dysfunctions in male and some reduced fertility in female. So some selected girl may request to perform colectomy with ileorectal anastomosis. Restorative proctocolectomy, it resects the colon and rectum and preserve the anal canal and the sphincter. Then perform anastomosis between the small bowel, between the end of the ileum and the anal canal. This will be anastomosed here. The anastomosis may be straight line or maybe after creation of the pouch or reservoir from the end of the small bowel. Ileal pouch. This is most important to create ileal pouch like S pouch, J pouch, W pouch. Constructed using several designs. The J is the simplest with a lower complication rate and mostly used today. Then anastomose the end of the small bowel with the pouch created to the remaining part of the anal canal. As this picture, this is the pouch created and this is the anastomosis. The importance of this pouch to act as a reservoir to delay evacuation of the stool and reduce stool frequency and extend the urgency period. To avoid severe diarrhea associated with straight anastomosis between the loop of the ileum and the anal canal due to high pressure and passage of frequent loose stool. Ileal pouch anal anastomosis can be performed using handmade anastomosis or can be performed using circular stitching. What is the difference? Regarding handmade anastomosis, the surgeon usually perform mucosectomy, remove the distal rectal mucosa, and perform the anastomosis just at the dentate line. This technique sought to remove all the diseased mucosa and no surveillance required. However, some recent evidence suggests that there is still some mucosal nest and that endoscopic surveillance is also still needed. Using a stapler. What is the problem of using a stapler? To apply the stapler, you need to leave rectal cuff. So this rectal cuff, present rectal cuff here to allow for the stapling between the native rectum and the pouch may be the site of recurrence of cancers and need long time surveillance. So with circular stapler, it's more easy technique and it's less time consuming. However, there is usually cuff of the native rectum that require lifetime surveillance. So to perform handmade anastomosis or to perform anastomosis with circular stapler is a matter of debate between pediatric surgeons. The challenge facing the pediatric surgeon for the operative treatment of ulcerative colitis, whether to perform single-stage surgery or staged approach. You can perform removal of the colon and rectum, total proctocolectomy, and you can perform directly the ilioanal anastomosis in a one stage. This will be rapid. No need for multiple surgery. However, high risk of complications, of leakage, of infections. You can perform staged approach, only perform removal of the colon and performing stoma. Then in the second stage, you can remove the remaining rectum and perform the anastomosis with creation of loop ileostomy until healing of the anastomosis. Also, the challenge will be related to using pouch or straight pull-through. Usually, pouch is the creation of the reservoir from the small bowel. However, this pouch may get inflamed, what's called pouchitis. There is maybe leakage. There is maybe twist of the pouch, obstruction of the pouch. Straight pull-through is either maybe used in some cases. However, there will be diarrhea, increased peristalsis, and high pressure. Pediatric surgeon may use laparoscopy or open surgery, may perform mucosectomy or stapler using a pouch anal anastomosis. This table summarizes the single versus staged approach. This is a single approach. This is 2 stages, and this is 3 stages of surgery. Indication, advantage, and disadvantage. The pediatric surgeon should choose between these options depending on clinical condition of the patient, depending on experience of the pediatric surgeon with various technique, depending on the state of the disease, the nutrition of the baby, the consultation of the parent and the patient. If the condition allows flexibility, they should be including in this discussion. Single surgery, 2 stages operation, or 3 stages surgery. Also, this table demonstrates the difference between the pouch versus straight ileal pull-through. Pouch will be helpful to decrease stool frequency, better fecal continence, however, with a risk of pouchitis, inflammation, leakage. Straight ilioanal pull-through remain an option in rare cases when there is limited length of the ileal mesentery and the pediatric surgeon cannot bring the pouch or create pouch and bring it easily without tension to be anastomosed to the anal canal. Also, this table demonstrates the difference between laparoscopy and open laparoscopy. No doubt, reduced time, fewer adhesions, improved scarring. However, they require advanced skills. Mucosectomy, complete removal of the mucosa, no further surveillance. However, there is a debate about this point, performing the anastomosis at the dentate line. However, there is maybe higher incontinence and soiling technique. Stapler, you will need to leave a cuff of the native rectum, which may be the site of recurrence. However, it is technically easier. It needs long time surveillance. The post-operative management will be summarized as most important is prophylaxis against DVT, steroids gradually tapered and discontinued, ileostomy closure after 3 months, child need frequent small meals and low residue lactose-free diet. Small amount of rectal mucosa, if present, will remain long time endoscopic surveillance. Surgical complications after proctocolectomy, the mortality is very rare. The most common is adhesive bowel obstruction. And in about 30% of patients may need re-surgery, and sure, the rate is decreased with using laparoscopy. There is some reported cases of wound infection, pelvic sepsis, anastomotic stenosis that is amenable to dilatation, anastomotic leakage, and fistula formation. The outcome of the surgery for ulcerative colitis is very important, especially for the patient and families. These four items is very important regarding stool frequency and fecal continence, regarding pouchitis, fertility and sexual function, quality of life. Stool frequency and fecal continence in the early post-operative period, the stool or bowel motion will be from 5 to 15 times within 3 to 6 months. The frequency decrease to 3 to 8 per 24 hours. Then the children will have 5 to 8 stool per day until their pouch become functional and create the stool and contain the stool. Patients are generally advised to avoid caffeine, high sugar, spicy food, use wood-soluble fibers to thicken the stool, use the toilet frequently, hold the stool at first sensation to strengthen the sphincter control, start probiotics to decrease the risk of any pouchitis. What is pouchitis? It is idiopathic inflammation of the ileal bowel creation. Inflammation of the bowel, usually clinical diagnosis present with loose and frequent stool with or without blood, cramping abdominal pain, tenesmus, urgency, and sometimes fever. Biopsy of many cases of pouchitis may relieve that the diagnosis of the disease is a Crohn's disease, not ulcerative colitis. When pouchitis is severe or recurrent, anatomical causes should be considered. There is maybe twist of the bowel, maybe obstruction. So the pediatric surgeon should search for an anatomical error in performing surgeries that may be the cause for the presence of pouchitis. The treatment, most cases respond to short course of oral antibiotics. The probiotic may have a role in their maintaining remission. Also, infliximab may be used in some refractory cases, especially if associated with Crohn's disease. Regarding fertility and sexual function, there is a possibility for subfertility and sexual dysfunction and should be taken in consideration in children. Sexual dysfunction may be related to the presence of sexual complications. Following restorative proctocolectomy, up to 50% of women demonstrate sexual dysfunction. If there is a complication, leakage, infection, pelvic sepsis, this increases the possibility for sexual dysfunctions. Without complications, this rate is decreased. Quality of life. Regarding quality of life, overall the quality of life is good, comparable to the normal population. In about 1/3 of patients, decreased quality of life is related to the occurrence of surgical complications. Impairment of the bowel function, high stool frequency will lead to decreased quality of life in these children. However, surprisingly, majority of the patients are satisfied with the operative outcome. Although they may have recurrent pouchitis, nocturnal bowel motion, occasional soiling, extraintestinal manifestation, this improvement may reflect the poor quality of life before ileoanal pull-through. So the child compare the condition before and after surgery. So you can imagine that the problem is so severe before surgery. So even in the presence of this complication, the child is somewhat satisfied by the results of the surgery. Now the question, what is the role of surgery in Crohn's disease? In Crohn's, surgery is not curative, reserved for the complication. Fistula, perforation, bleeding, toxic media colon, strictures, not curative surgery. The indications for elective or semi-elective surgery may be in continuing disease activity not controlled by the medical treatment, in gross failure not controlled by the medical treatment, obstructive disease without inflammatory activity, fibrosis or obstruction, you need to remove this obstructing segment, obstructive segment unresponsive to optimized medical treatment. Timing of surgery. The surgical consultation in the Crohn's disease should be started very early, and that the parent and children should be understand that the surgery may be needed for more than one times in Crohn's disease. And it's very important that surgical interference should be performed before puberty to allow for growing, for catch-up, to allow the child to reach to the optimum height. If surgical interference is delayed after puberty, the child's final height may be compromised and no catch-up growth occurs. How to operate in Crohn's or the surgical options in Crohn's? All options will be limited to the disease areas. Maybe segmental resection, maybe ileocolic resection, segmental or total resection of the colon, stricturoplasty, and very rarely total proctocolectomy. Preoperative assessment, it's very important, as in ulcerative colitis, the pediatric surgeon should consider that Crohn's may present with colitis. So the differential diagnosis between ulcerative colitis and Crohn's may be very challenging. So in order to reach the diagnosis, the child should be evaluated with upper and lower endoscopy, with endoscopic histology or biopsy markers, capsule endoscopy, magnetic resonance enterography. It's very important, trying to reach the diagnosis. The preoperative discussions, as with ulcerative colitis, should include the goals of the surgical therapy, expected complication, high probability of the recurrent disease, and redo stoma care. Operative approaches, we will go through some operative approaches. In duodenal Crohn's, which is very rare, may cause obstructive symptoms or ulcer-like hemorrhage, initially managed medically with anti-TNF agent and proton pump, but eventually many patients may need surgical intervention. In mild recurrent obstructive symptoms, if amenable to endoscopic balloon dilatation, it will be well and good. In more severe cases, we may need to perform gastrojejutinal bypass, with or without duodenal stricturoplasty. Duodenal resection are associated with high complication rate, so should be avoided. In a small bowel, jejunal, ileal, or ileocolic, small bowel resection is indicated in if there is a perforation, fistula, extreme bowel wall thickening that prevent stricturoplasty, close adjacent stricturing for 30 cm or more, ileocolic involvement. So resection will be limited to specific situation. Stricturoplasty is more commonly performed if there is short segment less than 10 cm with a linear diameter of 2 cm or less. The longitudinal incision is made through the stricture area, and then this incision closed transversely to widen the lumen. This is called bowel-preserving stricturoplasty. Endoscopic dilatation is a valid technique in endoscopically accessible short stricture, especially for recurrence after ileocolic resection. So in the small bowel, you may resect in a specific indication, stricturoplasty or bowel preserving stricturoplasty and endoscopic dilatation. For a large bowel, colonic Crohn's disease, challenging for the pediatric surgeon, as the diagnosis may be related to whether the case is Crohn's or ulcerative colitis. More common in children aged 8 years or less, usually extensive and aggressive, and after segmental resection, usually there is high rate of recurrence. In severe cases with chronic Crohn's and anorectal involvement, the pediatric surgeon may need to perform total proctocolectomy and permanent ileostomy. However, most children usually against performing permanent ileostomy. Surgical treatment for chronic Crohn's is controversial, to perform segmental resection or to remove the colon, subtotal colectomy. After segmental resection, the reported results show that the reoperation rate exceeding more than 80%. There is a significant percent of patients will need, again, colectomy. And also the rate of the permanent ileostomy is similar as after subtotal colectomy. So the debate and opinion expert is still divided to how to manage or to deal with chronic Crohn's disease. Segmental resection only removes the area affected and anastomosis, or subtotal colectomy. Patient with extensive colitis, Crohn's disease, subtotal colectomy and ileostomy may be a valid approach. Despite there is a high rate of clinical recurrence, there is reported 10 years rectal sparing is about 75 to 86%. Patient with severe rectal inflammation, Crohn's disease with severe rectal inflammation. Some pediatric surgeons suggest to perform ileostomy and treat the rectal inflammation, then perform again ileorectal anastomosis after rectal inflammation is medically controlled. Because of the relatively high risk of anastomotic leakage after anastomosis, temporally diverting ileostomy is also advised. So in case severe Crohn's with severe rectal inflammation, some pediatric surgeons recommend diversion, ileostomy, and the child will receive medical treatment for treatment of rectal inflammation. After the treatment, you can re-anastomose the ileum to the rectum. However, for fear of complication, you may need to perform temporally diverting ileostomy. Ileal pouch, like in ulcerative colitis, proctocolectomy with ileal pouch. Not generally recommended because of high rate of fistulization and pouch failure. However, in highly selected patients with isolated colonic disease without ileal or perineal involvement, restorative proctocolectomy with ileal pouch may be considered in some cases, but generally it is not recommended. What about fistula? We said at the beginning of the presentation that the Crohn's commonly presented with perianal disease or fistula and also enterocutaneous fistula. So it's quite common. Managed directly or by diversion, these lesions may be extensive and need to be evaluated with CT, MRI to know the extension and the track of the fistula or the sinus or abscess. Perirectal abscess should be drained, fistula controlled with fistulotomy for the simplest cases, or CTON will usually control the recurrent abscess and provide symptom relief. And it can be left for quite some times if it's not causing discomfort. In patients with severe perianal manifestation, simple diversion is not usually effective for healing the complex perianal disease. And some options may be needed, like to perform proctectomy, removal of the rectum, rectosigmoid resection, proctocolectomy with ileostomy. So the perianal disease in the Crohn's disease is very important for the pediatric surgeon, and the management may be challenging. It's not present in ulcerative colitis. The outcome after surgery in the Crohn's post-operative recovery is usually good. There is a recurrence rate increasing with time following resection, reported to be 50%, 73, 77 at 1, 5, and 10 years. Preoperative complications are not uncommon and include the wound infection, bowel obstruction, as many as in 25% of cases. Adult series demonstrate reduced rate of the post-operative recurrence with using anti-TNF biological drugs, but pediatric studies are still lacking. Despite the inability to cure the Crohn's disease, the pediatric surgeon should approach this problem with hope and take the opportunity to provide the child with time free from symptoms. So the pediatric surgeon must do the best for getting the child with time free from symptoms, trying to solve the problem, must approach the patient with hope. The third and the last one is what's called indeterminate colitis. We said that the inflammatory bowel disease may be ulcerative colitis, Crohn's disease, and maybe in some cases there is no clear demarcation between ulcerative and Crohn's disease, usually diagnosed in about 10% of inflammatory bowel disease patients. Usually it's easier to rule out ulcerative colitis in a child with Crohn's than Crohn's in a child with ulcerative colitis, as the Crohn's disease may show skip lesions, may be extensive, may include the small or the large bowel. However, ulcerative colitis usually occurs to the rectum and the colon. Children with indeterminate colitis have usually early age of onset of the disease, and disease rapidly progresses to pancolitis. From a surgical point of view, ulcerative colitis should be ruled out in the cases of indeterminate colitis. Why? Because number one, the surgery for ulcerative colitis is restorative proctocolectomy that is not suitable for Crohn's. To remove the colon and rectum and perform bowel. If it's performed in the Crohn's, there will be a high rate of complication, fistula, abscess, leakage, recurrence. So it's very important for the pediatric surgeon try to rule out the presence of ulcerative colitis in cases with diagnosis of indeterminate colitis. The long-term success of colectomy and pouch anal reconstruction for indeterminate colitis is about 73 to 85% compared to 89% for ulcerative colitis. Although these results support the consideration of performing colectomy and pouch anal anastomosis in the cases of indeterminate colitis, the patient with indeterminate colitis showing features of Crohn's may benefit from delayed pouch anal reconstruction for 6 to 12 months after colectomy. Delay the anastomosis and give medical treatment to be sure that there will not be a complication related to pouchitis, inflammation, sepsis. Ultimately, the operative decisions are based on the age of the patient, severity of the disease, urgency of the operation in case of indeterminate colitis. Children younger than 80 years of age with the diagnosis of indeterminate colitis should undergo colectomy, and the surgeon should proceed cautiously before reconstruction. Leave the ileostomy or stomas for some time and go very cautiously before you perform the reconstruction for fear of the diagnosis of Crohn's disease with many complications. Finally, acquired causes of the bowel symptoms as infection, parasitic gastroenteritis, Clostridium difficile infections as the cause of the symptoms must be ruled out. There is also very uncommon conditions like Behçet syndrome and chronic granulomatous disease that may mimic Crohn's disease. So these conditions may enter in the differential diagnosis in cases of indeterminate colitis. So our topic today is very important for all pediatric surgeon and pediatrician. We speak about IBD, inflammatory bowel disease. It is a type of inflammation and autoimmune dysregulation affecting children and adolescents. Ulcerative colitis, characterized by inflammation and superficial ulceration of the colon and rectum, usually start in the rectum and progress proximally to affect the colon. In some cases, there is pancolitis, and in these cases, the rectum is usually severely affected. Sometimes there is backwash ileitis, and there is inflammation extending to the terminal area. Crohn's disease, described at first as a regional ileitis, nowadays considered to be affecting any part of the gastrointestinal tract, characterized by granuloma, thickening, fibrosis. Maybe there is maybe skip lesions characterized by the presence of the perianal disease, non-healing fissures, non-healing ulcers, fistula, large skin tags. The incidence and the pathology is described in details. In case the presentation, in case of ulcerative colitis, usually diarrhea, but often bloody. In case of the Crohn's, there is usually weight loss. Regarding the treatment, there is large categories of the medical treatment and another on the surgical options. Medical treatment, what the pediatric surgeon should know about the pyramid of the current medical treatment since its development. And regarding surgical treatment, surgical option for ulcerative colitis will be curative to remove the colon and rectum, which is the site of the disease. However, in Crohn's disease, the treatment is mainly reserved for the complications. The pediatric surgeon should be restricted to the site of the disease part. Otherwise, if the pediatric surgeon remove large amount of the bowel, the child may have spinal failure or short bowel syndrome. So the pediatric surgeon should be deal with the disease side. It's very important that there are patients' perspectives in inflammatory bowel disease, including the fear from stoma, fear from resurgery and redo. And usually the patient read more and more information and sophisticated complications about the disease. The pediatric surgeon should provide time for the patient and explain very honestly and very clearly expectation for continence, post-operative complications, time for surgery, time for time for the need of the redo, if there is a chance for redo, time for post-operative feeding, types of the feeds, types of the drugs delivered during the post-operative periods. A very important point in the IBD is IBD and hernia. For the pediatric surgeon, especially in Crohn's disease, as this patient may need multiple operations and reoperation. The hernia may be parastomal, may be incisional hernia. The pediatric surgeon put this in consideration, how to deal with hernia in this patient, expected to have multiple surgeries and multiple operations. And finally, there is a group which is called indeterminate colitis. There is no clear demarcation. And the worst scenario is that the diagnosis is in the Crohn's disease. So the pediatric surgeon at first should exclude ulcerative colitis as the treatment is different. Proctocolectomy with pouch, anal anastomosis. If this is performed for the Crohn's, there will be many chance for developing complication. So the pediatric surgeon must do the best to diagnose and exclude ulcerative colitis. Finally, pediatric surgeon should approach this problem, IBD, ulcerative or Crohn's, with hope, with aiming to give the child time free from pain, free from symptoms, and provide at least good quality of life for these children. I think the subject is very important for all pediatric surgeon and pediatrician, and more studies are needed to understand the etiology, pathology, complications, and presentations management. Many researches are ongoing, trying to solve many problems still facing the pediatric surgeon. Thank you very much for your attention, and see you in next subject of pediatric surgery made easy. Thank you very much.